also agree with me that still we do have patients who are not very clear whom to approach when they have hair loss? Because even now I see some patients coming and ask me, doctor, do you see for hair?
Yes.
So do you see that confusion in patients?
Of course. So with patients in general, they always are more confused. And because the specialty, the real specialty which deals with the science of hair and hair disorders actually is called dermatology. So that itself is a problem, because dermatology means skin, but in reality, dermatology is the degree which deals with skin, hair, mucosa, and nails. So we deal with all the four things, but this is not very clear to the patient. So those who are suffering from hair or hair disorders actually ideally should consult dermatologist. So that is the first line specialist which they should consider. But there is a lot of confusion regarding this. So mostly they approach general physicians, or many times quacks, or many times they just want to follow some key ideas by some reels by someone who is not qualified in any medical field at all, and they would be giving some treatment advices. So that is the problem. So by the time they reach to the real doctors, in many cases it's more late.
So a dermatologist is a true trichologist.
So
actually.
a dermatologist is the true trichologist, and this trichologist term itself is a problem, because as such there is no degree which is trichologist. So many people, so there are many so-called self-proclaimed trichologists. They just do some 1 week, 2 week courses, and they start claiming themselves as trichologists, which is not the case. So only dermatologists are the true trichologists in that sense.
Yeah, so basically, dealing with the diseases of hair is not just as simple as just applying minoxidil or any nutraceutical or vitamin supplements. So we have to differentiate it with scarring alopecia, the experience which I was sharing, and other systemic diseases also, and which cannot be learned in just 1 week or 2 weeks of training. Because we have been seeing on social media a lot of non-dermatologists and even non-doctors also posing themselves as trichologists. That is one. So now moving on to the actual topic of early onset hair loss. How do you define early onset? How early is it? Is it 30, 20 or 40?
Okay, so early I would say is in terms of patterned hair loss or androgenetic alopecia. So those having the miniaturization of hair and signs of androgenetic alopecia below 20 years, I would like to call them as early onset hair loss in true sense. Some variation, some levels of miniaturization will be seen in 30s and 40s depending upon the genetic history. But now we are seeing androgenetic alopecia as early as 14, 15, 16 years. So these are the cases which I like to call them as truly early onset hair loss.
Yeah, so even though literature says less than 30, some literature mentions 30 as the early and cutoff age for early, but there is a variation.
Yes.
And as you said, now you are seeing androgenetic alopecia in 13, 14 also. What's the age of your youngest patient?
For androgenetic alopecia, the youngest in which I have done hair transplant is 20 years, but for scarring alopecias and others, we do hair transplant in many children also.
No, other than hair transplant, basically, androgenetic alopecia in children, what's the age of your youngest patient you have seen?
Youngest, yeah, I would say 14 years.
14 years, yeah, right. See, because I see there is an increase in the number of patients who are coming with early onset hair loss. Okay, what do you think are is contributing to this actually?
Well, see, I believe first of all genetic factors in terms of evolution. Hair is not an important organ for us, so that's why we are gradually losing it. And in addition, now with our lifestyle, this itself we have much more stressful lifestyle, and other genetic factors and epigenetic factors now contribute to this. And this we are constantly seeing that the father started having baldness say in his 40s, his next generation is starting to have it in 30s. So this we are seeing consistently, but there is significant genetic variations too. I have seen, I do treat. There are families in which I have done the transplant for the father, and now they bring their children, and one of them is bald at 20s and other one is having good hairs. So a lot of it has to do with genetic factors. But epigenetic factors, stress, this also plays a role.
So basically diet, lifestyle, smoking, one of the
Yes.
most contributing
Yes.
factors.
Yeah.
Obesity, increased insulin resistance. As Asians, we put on more fat in the abdomen. We have more of visceral fat, which actually increases the risk of insulin resistance.
Yes.
Once insulin resistance increases, then automatically the androgenetic alopecia progresses faster. And there is increased consumption of whey protein also, basically whey protein, lot of gym supplements which patients are taking. I believe that also happens to be the contributing factor.
Sure.
And even in both girls and boys actually, even girls also, obesity is one of the factor which is making them predisposed to PCO. And that itself is making them lose hair at quite early onset.
Yes.
Like I have patients who had developed almost female pattern hair loss, grade 2 to 3 at the age of 15 years.
Yes.
So that is the thing.
So I believe metabolic syndrome has the entire nation. So a lot of people are having metabolic syndrome, and they may not be even aware about this, that they are having. So this itself is one of the big problems. Another issue is now with this gym culture, in gyms it is a trend that every gym trainer, they just want to sell you their protein powders, whey protein, and this is because they get incentive out of it. The reality is most of these supplements have androgenic products built in them for muscle building, and this does increase hair fall. So I recommend to all, see, unless you are a professional athlete, first of all, in most cases, you need to improve protein in your diet. You actually don't require a separate protein unless you are having some specific problem or you are a professional athlete. Those who go to gym for 1 hour a day for 3 to 4 days in a week, your workout is not enough for your diet. Protein itself is going to be sufficient just for that.
So how do you proceed with these adolescent girls and boys, Dr. Kavish? Would you like to investigate them, both girls and boys, when they come with, I'm mainly confining to myself to androgenetic alopecia, not basically telogen effluvium and all. So do you investigate them? How do you proceed normally?
Yeah, in most such cases, now in almost all of these cases, I prefer to do nutritional analysis and hormonal analysis because first of all, I am seeing that most of them are deficient in vitamin D and vitamin B12, so that is quite common. And in addition, many of the females have iron deficiency, and in the hormonal profile, many of them have thyroid issues, and many of them have metabolic syndrome. So we need to find out whatever are the contributing factors to their hair loss, and then we have to treat. Just giving them minoxidil or some nutritional supplement is not going to be enough. We need to try and find the root cause and treat it holistically.
So holistic treatment is the final thing that as dermatologists we need to do it. So apart from all these, basically in all the girls who present with female pattern hair loss at such a young age, basically I go for a complete hormonal profile, looking for the androgens and thyroid disorders and insulin resistance. Whereas in boys, basically, if they are in the pre-pubertal age group, because these days we are seeing even 9-10 years boys also having female pattern hair loss. So pattern hair loss. So in pre-pubertal age group, I tend to refer them to an endocrinologist normally. Okay? And usually what I see is basically at that age group of 14-15 years, even boys don't present with classic bitotemporal recession. They usually present with little diffuse pattern, female pattern. They don't have a recession of the frontal hairline, but they have overall thinning in the volume of the hair, basically.
So I see in terms of those, most of the male patients who have diffuse patterned hair loss, this is mostly linked to metabolic syndrome. So this I have seen in many patients. So in many of those you will find insulin resistance, and it is linked to metabolic syndrome. Now in general, for you all, in terms of testing for all hair fall patients, it's a good idea to test for serum ferritin, vitamin D, B12 and TSH. These four are the basic ones, which I do almost in all. In female patients, especially if I'm seeing any signs of hyperandrogenism or there is cycle irregularity, then I go for a basic PCOD profile with all LHS, FSH, free testosterone and a general polycystic ovarian syndrome profile.
In this, like LHFSH is something which I generally don't do it actually. So now coming to the most important point is, how do we counsel the child and their parents? Because we are talking about adolescent age group, so I would call them as child. So child and their parents about the treatment, because the toughest part is that they have to start using minoxidil at that age of 14, 15, and they have to keep using it. So how do you normally counsel them? What do you tell them actually?
See, first of all, yes, it's very important that their guardians or parent has to be present, because then in terms of counseling, they need to understand what they are dealing with. So first the thing is that you need to reassure them, because many of them, what they are feeling is like there are female children 16, 17, they are coming, and then their common the idea in their mind is the rate at which I am losing hairs in the next few months or next few years, I will go completely bald. This is a very common notion which these girls have. First of all, so I tell them to see this is not going to happen. So first of all, you stop worrying about it. This is not the case, and we would be able to deal with it. But it's just that it takes time. It requires patience. Second question is very common, that they ask till what time I need to keep taking treatment. And then my answer is, till the time you want to protect your hairs, you probably will require treatment. It may not be at the same level. We might be able to reduce the dosing, but the treatment would be required. Hair loss is a progressive phenomenon. If you have patterned hair loss or androgenetic alopecia, you cannot eradicate it, just like you do treatment for diabetes or hypertension or otherwise. You might need to take treatment for long term. I prepare them for this again and again, because this is a common thing. They would feel that, no, why should I take medicine all the time? But they need to understand that they need to continue the medications in long term, and it is important, and you need to reaffirm this point again and again. And in terms of response, many of them are initially, the children are more impatient. So they would take treatment for 2 weeks and say, I am not getting response. It needs to be counseled. Let's see, response usually would be seen by 3 to 4 months. And in terms of hair improvement in hair thickness and volume, it may take 4 to 6 months. So you need to keep some patience. So you need to reaffirm these points very strongly. And the other thing which I also counsel them, say, if you want to continue treatment with me, I can guarantee you that I will control your hair fall within 6 months. And then the treatment has to be continued, and you should not mix any other treatment or desi treatments or others along with my treatment. If they do it, then I don't see them further. I say that then you do whatever you want to do. If you want to follow my advice, you have to follow it through and through.
So usually I tell them is basically, instead of applying oil, okay, just apply minoxidil. Get yourself pampered with your mom every day.
Yes.
And instead of going for that 7 steps Korean skincare regimen, they can just apply 1 step minoxidil.
Yes.
Have you ever used low dose oral minoxidil in less than 18-year age group?
Yes, mostly I don't prefer. I prefer using minoxidil lotions only. But in some cases in which I have to use minoxidil and patient is having irritation and problems with minoxidil lotion itself, or their seborrheic dermatitis getting aggravated, some of them tends to get migraine because of minoxidil. In those cases, then I do prefer to shift. And in terms of response in general, I am seeing a better response with oral minoxidil than with minoxidil lotion in general. So that itself is one of the case, and then compliance is better, response is better.
Yeah, so in which subset basically, in general for pattern hair loss, in which subset of patients do you use oral minoxidil? Have you shifted your practice from solutions to pills? The
No.
entire Western world is immune to pills.
No, so first choice is still minoxidil lotion. I would use low dose oral minoxidil directly as a first choice in someone having diffuse unpatterned alopecia. So if I am seeing miniaturization in the donor area itself, then I will directly go to oral minoxidil. Then there is no more point of using minoxidil lotion. This is point number 1. Secondly, in general, in those with diffuse thinning and with this kind of metabolic syndrome or diffuse patterned hair loss itself, I'm also seeing better response with low dose oral minoxidil. So those who present with very typical androgenetic alopecia, in them, my first choice is minoxidil lotion only.
Some minoxidil non-responders basically who has sulfotransferase deficiency, probably in that also. And the main problem what I feel with the topical solutions is the dryness and the frizziness usually.
Yes, yes.
So that is one more reason why I shift to oral minoxidil.
Yes. Now, but there is one interesting thing which many of you might know. What we are now starting something which would be for the first time in the world. Now what we are beginning is from next month we'll start to do a detailed genetic analysis. So genetic test for minoxidil sulfotransferase deficiency already exists, but we have developed a system where we can test a very detailed genetic analysis related to every part of hair fall pathogenesis, and then we can find out exactly what are the factors which are directly affected genetically in that patient, so that we can give a much more targeted treatment. So this kind of genetic test we have been working on to build it, and then very sure we will start to do this. So this, I believe, will kind of revolutionize the treatment going forward for hair loss, because we would be able to give a much more targeted treatment rather than giving a blind treatment, because we know minoxidil itself works in only about 50% patients, and then with peptides there are so many preparations, we don't know which one to use in which, and we give them based on our current clinical judgment. But if we are able to give them based on their genetic profile, we would be able to do a much better treatment.
This genetic testing, does this have a name, Dr. Kavish? And
No,
like
so
that?
this we are, we have
something
we
which
have
you are developing.
Yes, so we have developed it already, and this we would be introducing it very soon, and then anyone would be able to get this test.
Yeah, we are looking forward to it.
Sure.
Actually. Yes, coming to the next important thing, basically your field, I would say. Like, when do you actually go for hair transplant?
Yes, so this is a common question. So even for dermatologists and other practitioners who don't do hair transplant, you need to know about this, that because patients are going to ask you, doc, am I the right candidate for hair transplant? Should I go for hair transplant or not? There are two aspects. One is if the patient's hairline is receded and he wants to get his hairline back, then the only way to get the hairline back is by hair transplant. That is one part. Secondly, if the patients need to understand difference between thinning and balding. So if you have areas where there are hairs, you can see the hairs, but hairs are thinning down. Some part of scalp is visible, but there are significant amount of hairs in that area. That area is likely to improve a little bit with medical treatment and regenerative therapies. But the area has gone into more towards balding. It has gone completely bald. Then it is much more likely that only hair transplant would be able to help them. So if their purpose is to increase the density and to increase the volume overall, then they should consider hair transplant.
So in females, basically, do you find hair transplant to be as satisfying and as gratifying as in men?
Oh, with females, first of all, we keep hair transplant as a last resort. We always prefer medical treatment and regenerative therapies more aggressively. So we want to do non-surgically as best as possible. But in those female patients who, despite medical treatment and regenerative therapies, have significant loss of volume, then hair transplant becomes the only option. But with hair transplant, the biggest limiting factor previously was that they cannot trim the hairs, and in hair transplant, usually typically the donor area is trimmed to take out the hair roots. But now, because we have long hair FUE hair transplant, which allows us to take out hair with its entire length, so even for females, they don't have to trim hairs at all. So now this has made hair transplant in females much more easy, much more available for female patients to do without the need to worry for downtime. In terms of response, it is quite satisfying if they have correct target in mind. So if they have a limited area of baldness and you focus and cover that area, it works very well. Problem arises in those female patients who have diffuse thinning in the entire region. So those who have grade 3 pattern, female Ludwig pattern hair loss or more, so they have their entire area which is thin, then you simply will not have enough hairs to cover that entire area. In male patients, because we can take from beard and body, we go to much higher numbers in terms of doing hair transplant. But in females, we can only use maybe around 2500 grafts or so in a single session to do transplant. So we have a limited number of grafts available, and we can cover some limited areas, not the entire scalp. So one needs to understand what can be achieved and not achieved with hair transplant in females. So still medical treatment and regenerative therapy remains the cornerstone of treatment, plus with or without the hair transplant.
The problem in females is basically correction of the underlying hormonal
Yes,
part.
yes,
That is number one.
yes.
And usually in women, we see more miniaturization in the occipital area also,
Yes.
which we see through trichoscope. I think our time is done, so I just have a 3 rapid fire.
Yeah.
Okay. Is exosome going to replace PRP in future? Yes or no?
No.
No.
So, no.
Okay. What's future in trichology, in hair transplant? Any exciting things that are going to happen?
Oh, see, for as I told you, for hair transplantation, long hair FUE already is the future of hair transplant. If you can get the hair transplant done without any downtime, and you probably can get more instant results, then this is going to replace the usual hair transplant. So I believe long hair FUE is going to be the future of hair transplant. And in terms of medical treatment, I believe more genetically targeted treatment is going to be the future of hair transplant. And now we have lots of advanced regenerative trichology procedures also. So exosome may be equal to or maybe slightly better than PRP. I would keep it at the same level. There are even more advanced regenerative options, including stromal vascular fraction therapy,
Yeah, I was coming to that,
where
actually.
you're using autologous stem cell directly of the patients. Those are much more advanced therapies which are directly easily available. So I believe for medical treatment, genetically targeted treatment, for regenerative therapies, stromal vascular fraction and stem cell based treatment, autologous stem cell based treatment. And I would like to warn you also this, using stem cells from plant or from any other species or whatever, in my opinion, is not at all a good idea, and I am not in favor. So those so-called meso solutions and all which inject all this, I completely hate this idea. So it has to be autologous patients on stem cells when I'm using this term. And in hair transplant, the long hair FUE hair transplant is the future.
Thank you so much, Dr. Kavish. It was
Sure.
nice and in fact enlightening, both with the patient and the dermatologist point of view also.
Sure. Thank you.
Nice catching you up with Hyderabad. Looking forward to you again once again.
Thank you, ma'am.